Good evening. I wanted to share with you a small PowerPoint on chest tubes and chest tube insertion. So we'll be going over this in lab so you can actually see a chest tube. But I wanted to pull out some of the slides from the thoracic PowerPoint and give you a little bit more in-depth information as far as what to do with the chest tube, what it looks like, how it works. So this is a companion lecture to what we were doing already. Um, so I just wanted to we talked about pneumothorax and we talked about the hemothorax and we talked about flail chest and on tension pneumothorax. But I wanted to go a little bit more detail about the chest tubes themselves. So we talked about the pleural space and as there's those two parts of the pleural space, right? The one closest to the lung and the one closest to the ribs and the intercostal tissues and the muscles. And so we know we have that 10 to 20 mLs of fluid there in the pleural space. So when we're talking about a chest tube, we have several reasons why we would do it, right? We want to drain fluid, blood, or air that's trapped in that pleural space in order to expand the lung. We want to reestablish that negative pressure that is required to have the lung expand and the diaphragm contract and the chest to symmetrically expand. And then again, facilitating that lung expansion completely. So if the lung is expanded but not all the way, that's one of the reasons why we would use the chest tube. There's two videos here on chest tube insertion. So one is a more traditional chest tube like we would see in the hospital setting, usually more of an acute, following a trauma, following that iatrogenic, where we put in a central line, or maybe we did a thoracentesis and we nicked the lung and caused a pneumothorax. So that is more traditional. The second link on here is for a newer type of chest tube. It's called a single lumen pigtail. And you're going to see this more frequently for smaller pneumothorax or more lobulated, meaning they're in one area. These are a really good option. And that is one that is, it's much smaller and it does have a curl to it. And it has a wire that you pull that will actually like activate the positioning of it. So please watch those two. Like I said, one is more traditional, that's your more, 18-20 French size that you'll use in an ER surgery setting. And the other one is smaller, but we are seeing it. We are seeing it at Ohio Health. I have another video that I'd like to show you. This is more of an animation, meaning it's got some animation with it. It's done on a mannequin. So it is a little less gruesome, but it breaks it down in a little bit more detail. So I'd like to share that with you as just kind of a point of reference. Okay. So I'm going to go ahead and share that with you. Okay. If I can get it to share anyway. Okay. So here's the first video here that I'm going to show you. And this is a gentleman who is using a mannequin to kind of explain it. So this has a little bit more detail than it would if you were actually inserting it on a patient in actual real time. So this will have a little bit more information for you.
And draped. Prior to doing the procedure, we confirm one last time the reason why the procedure is being done and confirm the side that the procedure needs to be done on, in this case is left chest. We then confirm our anatomical landmarks, which is the nipple and anterior axillary line, which should represent either the fourth or the fifth interspace where the chest tube will be placed. We palpate the ribs in that area, and we will then make the incision, tunnel in above that incision, just above the rib. We will then bluntly dissect into the pleural space, holding the position with the clamp, after which point the tube will then be placed through the clamp into the pleural space. Ideally, once the patient has been appropriately again prepped, draped, and anesthetized, confirm placement, we then document the placement of the nipple at the junction of the anterior axillary line on the affected side. We then make an incision below the affected rib space. The incision needs to be large enough not only to accept the chest tube, but also to accept the clamp for the dissection into the chest cavity itself. The incision is made with any sharp knife that is then placed off the field so as not to inadvertently injure the operator or the assistants. You then take the blunt instrument, you then find your affected rib space, you then gently dissect in directly over the rib cephalad to where you are. thereby confirming the location. You then dissect into the pleural space. Once you have adequate entrance into the pleural space, the clamp is left in as a bookmark, if you would, to guide the passage of the chest tube, which is in place through the clamp itself, and then into the patient. Sometimes the chest tube will be assisted by placing the clamp around the tube to help guide it through the ribs and into the pleural space. Once the chest tube has been adequately placed, it then needs to be secured in a proper position with the placement of a suture in and around the chest tube itself. The chest tube may be secured in many different ways. We attempt to perform a single Roman stitch, whereby we tie it down to the skin first, locking it in place on the skin, and then having the suture go in and around the tube itself to then secure it to the skin stitch. Sometimes more than one suture is needed to perform this technique.
Okay. And then you can see where it is actually held in place with an occlusive dressing. Okay. And that's going to be really important because once you get that tube in and you get it connected and you get it sutured in place, you want to make sure that there's no air leaking around that insertion site. And so that's going to be really important because as we are extracting what is trapped in that pleural space, we want to make sure that it can come out, but that no atmospheric pressure is actually pushing in because that can disrupt the negative pressure again, and that can cause that lung to go ahead and close up. Um, so we want to make sure that we're doing as much as we can to ensure that the fact that the chest tube is actually functional. Okay. Um, so once we get that tube in place, okay, and once we get that sealed off to the chest itself, then we need to make a way for the air or the fluid or the blood to come out to be able to leave the pleural space, but not go back in. Okay, and so one of the ways that we do that is we have to seal it, and there's several options with this. One of them is called a Heimlich valve. And this can be something that is very elaborate, or it can be something that really looks like you took a large hollow tube, like a piece of rubber that is collapsed in one end, right? And what that does is it allows everything to flow out, but as that tube is connected, it will not flow back in. The other way is to use a closed drainage system with a water seal. If you remember when we watched a video on the tension pneumothorax, when we inserted the needle for the tension pneumothorax, we actually had a couple cc's of water in the syringe and we were watching the air bubble up through it. And we talked about the reason why is that water seal, again, allows the air to escape and we see it bubble up through the water, but then that air cannot enter back through. And that keeps the air from coming back in. So in addition, you can use a low level of suction. So if the pressure inside the pleural space is not enough to evacuate and go into your closed drainage system or into your tube, you can actually use a low level of suction. So in your book, they actually have a figure 36.9, which gives a little bit more in depth on what it looks like with a Heimlich valve. And again, many manufacturers, right? And with the closed drainage system, with the Thoraceal or the Oasis or whatever your facility uses. Okay, but the overall premise of this system, it has three separate chambers. So your first chamber is going to be your drainage collection, right? So that is going to be where any fluids then come into that first chamber. The second chamber is going to have a minimum of 2 centimeters of water, and that is going to function like we talked about the water seal. So any of the liquids are going to be in the first chamber, the air goes through the water seal, and then the third chamber is going to be our suction control. So negative 20 centimeters is going to be our most common suction setting, and that's usually what they come preset within the thoraceal. And you can either do wet or dry, meaning you can use air or you can use the water seal. But I just understand how those three chambers work and how everything is measured. So these are going to be positioned below the chest, and they're going to be connected at all times to our patient to that chest tube. So I'm going to show a video right now that is going to show you the setup of it. So I want you to watch this and then understand that we will be using models and different other videos and things in lab where you can do some hands-on. They look intimidating. When you pull them out of the package, they're gonna look very complicated, but they're very, very simple to put together, and, your job is basically to instill the water, to get it functioning, attach it to the suction, attach it to the patient, and then monitor. So that's really what our main objective is gonna be. So I just want to show you a video to show that it's really not as intimidating as you think it might be, but that there's lots of different facility policies and manufacturers. This is going to show you the Oasis, which is a fairly common one I've seen in multiple
Our
practices.
standard chest drain is the Atrium Oasis dry suction water sealed chest drain, as known as the Atrium 3600. It's stocked in the chest tube box. We also have the Atrium 3650, which allows for auto transfusion, and either can be ordered from SSP under chest tube drainage container. Remove the chest drain from the outer bag and perform hand hygiene. According to the manufacturer's recommendation, remove the blue wrap using sterile technique. Remove the chest drain from the box and rotate the swing out stand so it can stand on its own. Now we will fill the water seal. Remove the prepackaged 45 milliliter ampoule of sterile water from the back of the drain. Twist off the lid and squeeze the entire ampoule into the suction port located on top of the drain. This fills the water seal to the 2 centimeter line. Next, when the practitioner is ready, remove the tubing from the back of the drain. You may be asked to remove the sterile cap and then hand the patient connector to the practitioner to be hooked to the thoracic catheter. When indicated by the practitioner, hook up the wall suction to the suction port of the chest drain. At the wall suction regulator, turn on suction and increase suction to at least negative 80 millimeters of mercury. You should see the orange suction monitor bellows expand beyond the triangle mark in the suction monitor window, indicating that suction is working. The chest drain's dry suction regulator is preset to negative 20 centimeters of water, although it can be adjusted from negative 10 to negative 40 using the rotary dial on the side of the drain. Do not adjust this regulator setting unless ordered by the practitioner. Remember to keep the chest drain below the level of the chest at all times. You can sit it on the floor using the swing out floor stand, or using the multi-position hangers, you can hang it from the bed frame. Assess the dressing to make sure it is dry and occlusive. Inspect the skin for signs and symptoms of infection and palpate the surrounding skin to identify subcutaneous emphysema. Remove any dependent loops from the tubing by looping it on the bed or chair. This allows gravity drainage and prevents pressure from building up in the pleural space. Next, assess the quantity and quality of fluid in the collection chamber. Clearly mark the level of the fluid and mark the date and time. Next, assess for an air leak by looking for bubbling in the water seal chamber. Bubbling indicates there is an air leak somewhere in the system. It could be at the patient insertion site, in the tubing or tubing connections, or a crack in the chest drain itself. The graduated markings help to quantify the size of the air leak from 1 at the lowest to 5 at the highest. Bubbling may be continuous or intermittent. If it's a new air leak, you need to identify the source of the air leak and fix it if possible. To locate the air leak, briefly clamp the chest tube at the dressing. If the bubbling stops, you know the air leak is either at the insertion site or in the lung itself. If bubbling continues, briefly clamp the tube just distal to the first tubing connection. If bubbling stops, you know the air leak is in this connection. Try to seal it by reinforcing the connection. If bubbling continues, move down the tubing and clamp about every 12 inches or so to identify the source of the air leak. If you get all the way to the drain itself and clamp and still have bubbling, you know the air leak is in the chest drain itself. You'll need to go ahead and switch out the chest drain. Keep in mind in this whole process when searching for the air leak, never clamp the tubing for more than a couple of seconds or you risk a tension pneumothorax. Next, check for titling. Titling is the up and down movement of the patient pressure float ball in the graduated water seal chamber. With inhalation, negative pressure increases and the float moves up. And with exhalation, positive pressure pushes the float back down. With positive pressure ventilation, Titling will be just the opposite, and this is normal. You typically will not see titling with an air leak. Other reasons for no titling include a tubing occlusion, the lung is fully expanded, or PEEP, which can dampen oscillation. Titling is more apparent when suction is turned off.
So that's going to give you a lot of the preview of what we're going to talk about for the next thing. So after you watch the next part of this lecture, I want you to go back and I want you to watch that video, that how to, and it's going to touch on all the things we're going to talk about, but this is kind of is a frame of reference. And I want you to go back and make sure you understand why everything is where it is and what all those terms mean. Okay. So he said a lot of different terms in there. Which we're going to go over here in just one second. So titling is what he talked about. Okay, so titling is what he was talking about, that little water, that little white float that went up and down. So that indicates that there is that pressure change as they are breathing, right? So we want to see that. We want to see it in the water seal chamber. We want it to go up when they breathe in, and they want to see it fall when they breathe out. Okay. When they talk about positive pressure ventilation, so this is going to be your PEEP, right? And we're going to talk about this next week too when we discuss the ventilator settings. But you can have PEEP even with BiPAP. It's any type of positive and expiratory pressure that is going to be pushing in. So as the body is exhaling and the lungs are then shrinking back down, if we have PEEP and it's pushing in, so it's mechanically or artificially creating some pressure, then you're going to see some difference with this. But either way, we want to see titling as they're breathing because that indicates to us that it is a closed system, that we've restored that pressure. And as we breathe, it's going to slide up and down. If for some reason the titling stops, okay, that means one of two things. One is good, which is the lung has completely expanded, right? And that's going to indicate we need to get a chest x-ray. We need to do a thorough lung assessment. We need some vital signs. We need to notify the provider, or we're going to see that there's some type of an obstruction. Okay. Either way, what it's saying is that pressure, right, is as we're breathing, there's no pressure coming in and out of that tube, which is good if the lung is expanded, but it's bad if there's some type of an obstruction. If for some reason you're seeing constant bubbling, and you saw in that video how you could see that little bloop, right? You saw those little bubbles. If it is continuous, there is a leak, right? And I like that video because he shows you there's a whole system from the patient to the connector to the chest tube device itself. So there's lots of real estate that you need to check to see if there's a leak. And you saw how he did that, starting with the insertion site, going down. Now you notice he did not pull, he did not strip, he did not milk. It was a very quick clamp and looking at the bubbling to see where the leak existed. Okay. When you have someone who is on a chest tube, okay, they're in a closed chest tube system, there's a couple things that we need to really focus in on. And again, you've got a little blurb there, box 36.3 in the pink or purple pages, whatever color you think that they look like. It talks about the care of a client. So we need to follow ABCs, right? Airway, breathing, circulation, safety, discomfort, education, feeling. So ABCs, DEF, right? Obviously, we are assessing the respiratory status. We need to assess it continually, but clearly every 4 hours, right? Or any change in condition. We need to make sure that we are keeping the patient in the right location. We need to keep the system below the level of the lungs or the chest, making sure everything is where it needs to be. Okay. Once we're sure that the respiratory status, the airway, the breathing, the circulation, we're checking the vital signs, the oxygenation, shortness of breath, symmetrical chest expansion, lung sounds, all the things. Once we do all of that, then we need to go into our safety. And that is what preparing what's at the bedside, right? So we need to make sure that we have all of the connectors, but you also have things that you might need in an emergency situation. So you need to keep hemostats, sterile water, and an extra occlusive dressing at the bedside. That would be in case for some reason that if the tube itself would get disconnected from the chest system, we want to make sure we've got a container of water that we can stick that tube in that then reinstates the water seal, right? So it doesn't have to be in that chest tube device the closed system. But we definitely, if it gets disconnected, we got to stick it in the water so we don't reintroduce that atmospheric pressure and cause that lung to recollapse then. Okay. The other thing we need to keep is an occlusive dressing on the off chance that it would be pulled out of the patient, right? So if that tube gets pulled from the patient itself, we now have an opening that can introduce that air back into that pleural space, which is what we were trying to avoid and trying to correct with a chest tube system. So we're going to cover that with an occlusive dressing. So as they breathe in, we are not pulling more air into that pleural space. Okay. And then we need to make sure that we are medicating for pain. This is uncomfortable. If you watch that video, as he inserts it, they are really kind of pulling and moving. We're separating the fascia, we're going above the rib and the intercostal muscles. And you know that if you accidentally hit that rib or you have a rib injury, it's very, very uncomfortable. So to have a tube in there irritating every time you breathe, it's rubbing and pulling. We want to make sure that we medicate for pain. Otherwise, the patient's going to splint, they're going to take short, shallow breaths, and that again is going to not promote our lung expansion. Okay. Avoid tension on the tubing. You saw in the video how they kind of looped it and laid it on the bedding itself. We don't want it stretched, right? We want to promote gravity. We want to have the flow that goes down, but we want to make sure that we're not pulling on that as well. Okay. We have to monitor for drainage, especially if this is a hemothorax. We want to make sure after you put this in, you're going to get an initial output, right? We know that. And we know that it's going to be a certain amount and we're going to mark it. Okay. So after the initial insertion, we're going to mark it. For the next 24 hours, we are going to do an hourly mark. Okay. What he showed on the video with the two different types of chest tubes, there is one that has a reservoir where you can then auto transfuse that blood back in. We're talking about the regular closed chest tube drainage system that you would see that is for a patient that is not having a over amount of drainage. So hourly for 24 hours, then at least every 8. Okay. Anything that changes after that initial output, if you're getting more than 70 an hour, 70 mLs an hour, if the color changes, it gets thicker, it gets deeper red, it starts to change in consistency, we definitely need to let them know. Now, please keep in mind too, as the patient is coughing, turning, deep breathing, and moving, you may have little bursts where you get increased drainage, but it should not be continuously increasing. Okay. We're looking for anything that is red, anything that is inflamed, right? We do have it is an infection portal, right? We talked about crepitus, subacute emphysema, that Rice Krispies, right? And that would indicate to us that maybe there is air leaking at the insertion site. So instead of the air coming down the tube and into the closed chest tube system, it's leaking out into the subcutaneous tissue, and we're going to see some swelling, and we're going to have some crepitus Rice Krispies. They talked about clamping it. We're only clamping for little short periods of time, a couple seconds at a time. That's all we're going to do. And again, we are not pulling, we're not stripping unless a provider is standing at the bedside saying, go ahead and do this, or I'd like to do it. Could you come in with me? Anything that we are doing is going to alter that negative pressure. Okay. We don't want to increase it any more than what we have that preset -20 of water. Troubleshooting. Okay. So if you have a patient with a chest tube, we definitely want to make sure that we have that equipment at the bedside, the clamps, the hemostats, the water, the occlusive dressing. So again, if the tube comes out, plug the hole, right? Occlusive dressing. If for some reason it gets disconnected from the closed tube system, we're going to put it in water. Okay. So we want those bubbles to come out. If the tubing separates, right, if for some reason it comes disconnected um from the tubing itself, we're going to have them exhale and cough, and then we're going to clamp it off, right? So we don't want them inhaling while we have that open area where all that air can come right through the chest tube and go right back into that pleural space. So we're going to have them cough and breathe out. We're going to apply the hemostat. Okay, so troubleshooting tips. These are really important if you're caring for a client. And I've seen this lots of times where you go in a patient room, they're sitting up in a chair, they got the chest tube, it's taped to the floor, right? Everything looks great, but you look for supplies and there's nothing there. Because if it's going to go bad, unfortunately, you have to have everything right there. Right. We don't want our patient to end up back where they started with a pneumothorax or even a worse pneumothorax than they started with. Okay, couple quick questions, right? So here are our practice questions when it comes to this. So if you're planning care for a client who just had a chest tube inserted, right? Which of these interventions would we want to include? Okay, so I'm going to give you a chance to read through these. Do we want them to cough every 2 hours? We're going to check for continuous bubbling. Are we going to stir up the tubing every 4 hours? Clamp the tubing once a day, or obtain a chest x-ray. Okay, so you can hit pause if you'd like. And the answers are A, B, and E. Okay, so A was coughing every 2 hours. Absolutely. Going to promote our lung expansion. We want to do that. B, we want to observe for continuous bubbling. We do not want to see that because that does indicate an air leak. For C, we never want to milk or strip. D, we only clamp if we're checking for any type of a leak in the tubing or disconnected, and because we do not want to cause any type of pneumothorax. And E, yeah, we do want to get a chest x-ray, and that's going to verify the tube is in the right place. And you're going to do serial chest x-rays daily or any change in condition to make sure that it's working. Okay. So, assessing a client with a chest tube, which would be expected. Okay, so here's some findings: continuous bubbling, gentle, constant bubbling in the suction control chamber, rise and fall of the water in the water seal as they breathe in and out, exposed sutures that are not covered by a dressing, or the drainage system held upright at chest level. Okay, hit pause if you want to go through those. And the answers are B and C. What would we expect? We do not want to see continuous bubbling in the water seal, right? Gentle bubbling in the suction control, right? In that other chamber, however, is expected as the air is being removed. So gentle bubbling and the suction, we're okay with. Continuous bubbling in the water seal tells us there's a leak. Okay. C, that word titling, that tells us it's working correctly as that little white float goes up and down with inspiration and expiration. Okay. D, we want those sutures to be covered, right? It's still sutures. We want to make sure everything is occluded. And E, we want it positioned below the level of the chest. So we want to see B and C. All the others are findings we do not want to see. Okay. So that is just a quick little overview. We will go into more depth and get some more hands-on with the chest tubes, but please utilize the video links for the traditional insertion, the single lumen pigtail insertion, and go back and rewatch how they put together the chest tube. And that video is a little bit longer. It goes into a few other things and troubleshooting, how to set up the room, all good information when it comes to chest tubes itself. So thank you for listening. And this is, like I said, the companion to the thoracic lung cancer and laryngeal lecture that's posted from earlier this week.